All right, I think we're ready to get started. Welcome, everybody, to the COVID-19 healthcare provider update. I have a couple updates about the structure of these webinars going forward. For the summer, to accommodate everyone's schedules, we're going to be moving to a bi-weekly webinar, so there won't be a webinar next week, but it will return the Friday after that at 2 p.m. We have a very packed webinar today, so there will hopefully be time for one or two questions, but we will have a poll at the end, and as usual, we will do our best to answer your questions in the chat while the speakers are talking. Please participate in the poll at the end. It'll help us drive content, and it'll help us figure out how to get some information, get tailored information back to you. So our speakers today, we are seeing the triumphant return of Dr. Dimitri Daskalakis. We are really happy to have him back here. We also have Dr. Catherine Staten, the Director of the Injury and Violence Prevention Program, and we have Seth Goodhartz, who's the Director of the Office of Emergency Planning and Operations in the Division of Environmental Health. Also, today is the birthday of my mother, Dr. Shashi Foha, and I want to say happy birthday to her. And with that, I will give it to Dr. Daskalakis.
Great, thank you. I will also say happy birthday to Mom. Next slide. So we are going to have an illustrious panel, as you saw, starting with our normal Where Are We Now? So an overview of the epidemiology of what's currently happening in New York City and beyond. We will have a special focus highlighting our new and improved version 2.0 safer sex during COVID-19 guidance. We'll talk about recognizing and preventing domestic and intimate partner violence during the pandemic, and we'll end with preventing heat-related illness during COVID-19. Next slide, please. So this is our Where Are We Now? The COVID-19 pandemic is accelerating in some low and middle income countries. So we are actually seeing that globally new case count records continue to be set. In fact, it is taking fewer and fewer days to achieve the next million than it used to in the past. So we're seeing an acceleration. Cases are surging in many US states, especially in the West and the South. Some of these states are states that did not fully constrict, or they started reopening before they actually reached their peak. New York City began phase 2 of its reopening on June 21st, which already feels like a year ago. And current response strategy is to work to implement suppression measures while we are monitoring the impact of reopening. So work with tracing and case and contacts while we closely look at our indicators to make sure that we're not experiencing the beginning of a surge. Next slide, please. So I'll remind you that we're getting close to 10 million cases. We're at 9.1 million cases worldwide, almost 500,000 deaths. You can take a look on the map to sort of get a sense of where things are increasing, decreasing, or falling. So you'll see that there are only a few areas in the world that are experiencing that blue color, and we have a lot of folks in orange, including us in the United States. Next slide, please. This is also a view of cases and deaths in New York, in the United States. We have over 2.4 million cases. That's over a quarter of confirmed global cases of COVID-19. The red bars with the red line demonstrate cases, and it is the unfortunate reality that smoothed out 7-day average appears to be going up along with the sort of absolute case count by the bar graph. So it looks as if, as discussed on the first slide, that there is a net increase in the United States of cases. Now, new deaths continue to decrease, which may also mean a couple of things. One, there is an inherent lag between new cases and deaths, so it could be that we will see an increase in the future. But the other part of this could be a different population who is currently being represented by the cases of COVID, or potentially even milder cases being diagnosed. Next slide, please. So when you look at this map, it is similar to the other where blue is falling falling in red with the spectrum from yellow to orange representing increasing cases. So you can see which parts of the country are experiencing increases in cases. And, ultimately, I think it really speaks a lot to some of the reopening strategies that we've heard and seen, and tempers all of our enthusiasm, I think, for reopening, and really makes us want to take it slow, actually, like we've been saying for a while. Next slide, please. Now, this is our quick view of the epi of COVID-19 in New York City. The top panel is cases, the middle panel hospitalizations, the bottom panel is deaths. To date, we have over 210,000 cases, about 55,000 hospitalizations. We have 17,000 confirmed deaths. That's people who are COVID positive on a test, and another almost 5,000 probable deaths. But what you can see is that our epi curves have a nice tail at the end. So far, no deflections that would make us believe that we're experiencing an increase. Next slide, please. How would we know if there's an increase? Well, we have a very sensitive system called syndromic surveillance. These are data that come in from urgent cares and emergency rooms throughout the city. We're able to track admissions and visits for COVID-like illnesses. This graph actually shows you our experience with the syndromic data since January, and you can see pretty clearly that visits and hospitalizations really went very closely along with the pandemic in terms of a sign. In fact, visits will go up first, followed by hospitalizations. We are closely monitoring these indicators as well as others that the state is monitoring. And if we see deflections, that would indicate for us the need to potentially constrict some of the reopening strategies. Next slide, please. And this is really a aerial view of what we hope to see or what we expect to see during this phase of the pandemic. So we've made it through local transmission. We've made it through widespread transmission. We've experienced declining transmission, and we're sort of at this plateau phase where we're really focusing on suppression. And so suppression means pushing us to our next step, which is to try to, instead of doing population-wide interventions like closing down the city, you are curating social distancing by focusing on active case finding and isolation, contact tracing and quarantine, and doing whatever else we can do to maintain some physical distance and other precautions. So resurgences are possible during suppression, and that's why those indicators are so critical to be able to prevent large surges rather than small increases. And so with all of the work of H&H Trace, which is test and trace core, as well as our work with indicators and other functions in the city, the hope is that we maintain suppression and continue on to recovery, which will eventually ultimately also require such a thing as a vaccine, which we hope is not too far on the horizon. Next slide, please. So we also want to focus on some updated guidance. And so during suppression, it's going to be important to identify and exclude healthcare personnel who've had worksite exposures to COVID-19. Prevention of healthcare exposures has to take into account asymptomatic and pre-symptomatic transmission of COVID. So we have just released our most recent health advisory, number 20, that has some updated guidance on personal protective equipment, also identifying COVID-19 exposures in the workplace, and also exclusion after a workplace exposure. Again, this is all healthcare worker related. This is aligned with updated CDC guidance. Next slide, please. So there's some things that are new and some things that are a bit more nuanced, but everyone entering healthcare facilities should wear a face covering or mask. That's not changed. In addition to masks, the CDC now recommends that all healthcare practitioners use eye protection. That means goggles or a face shield for all patient encounters. Ideally, N95, not ideally, in every case where you are doing a aerosol generating procedure, N95 respirators or higher should be worn. Now, given ongoing N95 shortages, it's important to prioritize these respirators for aerosol generating procedures, and that means intubation, suctioning, high flow oxygen nebulizer, or locations where they often occur like the ICU. So our previous guidance of using surgical masks for other encounters continues to be the same, And as there's a change in supply chain for N95, guidance may change again in the future. Also, for evaluation of patients with possible or confirmed COVID-19, clinicians are still advised to use gloves, gowns, face masks, or N95 respirators if there's a chance of an aerosol-generated procedure, and also eye protection. So again, the big highlight is that eye protection is now sort of recommended for all patient encounters, not just COVID-related. Next slide, please. Asymptomatic healthcare practitioners with a workplace exposure to a patient, visitor, or other healthcare practitioner with confirmed COVID-19 should be excluded for 14 days. I will give you a big footnote here that this is CDC guidance and that New York State guidance actually is a bit different. So really talk to your employer to see which of the guidances they are actually recommending. Both of them are valid. The New York State guidance actually does allow healthcare workers to work after an exposure. But again, talk to your facility, and ultimately it's a question of scarcity of staff. So if there are no staff shortages and it's possible to do a exclusion of the healthcare worker who's exposed, that's great. If there are still exclusions, then again, there's some clear New York State guidance that allows folks to continue to work if they're essential healthcare professionals. Exposure is defined as any of the following. Healthcare professional did not wear a face mask or respirator and spent greater than or equal to 15 minutes within 6 feet of a person with confirmed COVID-19. So that's not very different. A new twist is that if a healthcare worker did not wear eye protection and spent greater than 15 minutes within 6 feet of a person with confirmed COVID-19 who was not wearing a face mask or covering, then that would also be grounds for exclusion under the CDC guidance. The healthcare worker did not wear all recommended PPE during a procedure that can generate aerosols. So those are the three situations in which the CDC would recommend exclusion. Again, please remember, New York State has different guidance, and that guidance is also valid, especially in the setting of staff shortages. Next slide, please. So now we'll move on to safer sex during COVID-19. Next. So if you've not seen it, available on our website is a document for patients. It's very patient-friendly and encourages healthy sexual behaviors and provides information on risk and precautions. And apparently it was so interesting it made the cover of the New York Post. Next slide, please. So the question that we've gotten a lot, and I'm sure you are as well, is it safe to have sex during COVID-19? And so our answer is pretty straightforward, that sex during COVID-19 can be risky because of how the virus spreads, and it's hard to have sex without being closer than 6 feet of each other. So close contact is one way that it can happen. And remember, usually when we think of STIs, we think of the waist down, and in this scenario, we're talking about the neck up. So we're thinking about saliva, mucus, and also breathing of people with COVID-19 that potentially generate the particles that could result in transmission. Now, although we'll speak briefly about where the virus can be found, there is no convincing evidence of transmission via semen, vaginal fluid, or feces. Next slide, please. So we also know that other coronaviruses aren't easily spread through semen or vaginal fluid, but we don't fully know the answer about SARS-CoV-2. There was a cohort study of men hospitalized for COVID-19 in China. 38 of these lucky participants provided a semen specimen while they were sick with COVID, and 16% had semen positive for SARS-CoV-2, and they were at various stages of infection. So the point is that there is potentially virus in semen, but based on other coronavirus experiences, it is unlikely that this is an efficient mechanism of transmission. Testing of vaginal fluid, however, showed that all samples were negative. So at least in a small study, there was no SARS-CoV-2 in vaginal secretions. Next slide, please. Also, we know that SARS-CoV-2 has been found in feces, but it's unclear if it's transmissible. Again, there have been gastrointestinal manifestations of disease, and there has been SARS-CoV-2 identified in feces. And so ultimately, though there is evidence that it could be possible for fecal oral transmission as a potential source of infection spread, we don't expect that to be a very a very efficient mechanism, since the most efficient mechanism is respiratory. So again, though it's interesting for surveillance, no real reason to test feces for SARS-CoV-2 at this point. Next slide, please. So then the next question that we get, other than is it safe to have sex, is should we have sex? Notice that there's a difference in that. So the answer is that, yeah, people should be having sex because it's what people do. It's natural, a big part of how we connect with others, and it's important for physical and mental health. So it's really our job as clinicians and public health to help guide people for how to have the safest sex they can have during a pandemic. Next slide, please. So that means that we have to educate our patients about COVID-19, including symptoms, transmission, who's at risk for severe illness, isolation, and length of infectious period, as well as what diagnostic and antibody test results mean. We also have to have open conversations with patients about risk and harm reduction strategies so patients can make informed decisions and be safe as possible. That means in our New York City Department of Health parlance, you have to bear it all and encourage patients to talk about their lives and with their sex partners. So it's important to ask patients about what sex they're having and work on tailoring advice to the patient, considering age, healthcare, other health conditions, sexual orientation, and lifestyle, and really work in shared decision-making to better answer the various questions folks may have around sex. It's also important to direct patients to good sexual health care and resources. Next slide, please. So, ways that people can stay sexually active while physically distancing, especially with those who are at higher risk of COVID illness. Well, we believe that a party of one is a good idea. So masturbation is very safe. We remind people to wash hands and any sex toys with soap and water for at least 20 seconds before and after sex. And we also say that if you plan to have a mutual masturbation experience, try to do that at a safe distance, and also wear a mask or a face covering, because heavier breathing may increase particle spread. We also think that in the age of technology, that virtual sex is another option that many New Yorkers have already taken up. Use video dates, sexting, chat rooms, and video conference parties with consenting partners. But we also remind people to disinfect their keyboards and touch screens if they're using them in that context. Next slide, please. So if you decide to go from 1 to 2, there are certain scenarios that are safer. So the safest is to limit sexual partners to folks who are already in your household. The second is to limit the number of external sexual partners to what in effect is a social pod or a social bubble. So a group of people, if you have more than one partner, a group of people who you are consistently exposed to, and have sex with people that you can talk about this stuff about. So it's important, just like with STIs or HIV, to have honest conversations and talk about COVID-19 in the setting of a pandemic. Next slide, please. So we, however, think that 3 is a crowd. So some patients may want to engage in riskier sexual activity no matter what. We cannot shame those patients, but instead we have to give them the information they need to be as safe as possible. So if folks are polyamorous or have more than one partner, you have to try to keep that group of partners as small as possible. If you're attending gatherings that include sex, you have to, we advise that you go with a consistent sex partner rather than meet others at that space. Pick larger, more open, ventilated spaces, and wear a face covering. Avoid kissing, and do not touch eyes, nose, or mouth with unwashed hands. And bring alcohol-based hand sanitizer. And as one of my patients reminded me when I told them, they said, make sure that you put it in the bottle that looks different than your lubricant. That is great advice. That you can tell the difference between alcohol-based hand sanitizer and lubricant in that scenario. Next slide, please. So it's important that folks talk about COVID risk factors with their patients or their partners, just as they would discuss PrEP, condoms, and other safe sex topics. It's important to ask prospective partners these questions. They're not perfect, because obviously asymptomatic spread is possible, but asking about symptoms is not a bad start. Asking about symptoms in the last 14 days, asking about COVID diagnostic testing if they've been tested, and also what have they been doing in general? Have they been hooking up a lot? Have they been practicing physical distancing? It's important to have some conversations to sort of get a sense of risk. Next slide, please. And then also, we have a lot of advice about when people are sick. So if you're sick, no matter how mild, avoid sex altogether, especially kissing. or if you tested positive for SARS-CoV-2 via molecular or antigen test in the last 10 days. So even if you have no symptoms. When is it safe to have sex again? So it's the same as what we've already said. Lots of time, same as isolation, 10 plus 3. So for most people, 10 days from the day symptoms started plus 3 days fever-free with overall reduction in symptoms off of all antipyretics. If individuals are getting tested and they're asymptomatic, we would say 10 days from the date of their positive specimen collection. We also have advice for 50-year-olds and mainly over 65-year-olds who are at higher risk for severe COVID-19 illness. It's to be even more judicious about your sexual activity. Consider avoiding sex with new partners especially, and be careful in terms of other precautions. So folks who are at higher risk should take higher precaution. Next slide, please. So other tips for patients. Again, we think that kissing is, though pleasurable and part of intimacy, something that you should skip, especially with a new partner. So use a mask or a face covering. We talked a little bit about the presence of virus in feces. Avoid rimming. That's a mouth on anus. Again, like, it is probably not that high risk, but since we don't have a lot of data, we need to at least sort of speak out loud and say, listen, this is something you may want to avoid since there could be virus there. You can use barriers like condoms or dental dams to reduce contact with saliva or feces, and also wash up before and after sex. Additionally, we also want to remind people to be creative. And so our little catchphrase here of make it kinky is what we've got for you, which is to be creative with sexual positions and physical barriers, whatever it takes to prevent face-to-face contact while allowing individuals potentially to have sexual interaction. And so New Yorkers are very creative, and I think really giving them guidance for how to prevent transmission is the right way to go. Next slide. So we also wanted to talk about using COVID-19 test results to make decisions about sex. So a prior positive diagnostic test or antibody test means the patient likely had COVID-19 and may be less likely to be reinfected. Please note the very strong may. So we don't know how strong protection is or how long it lasts. We also don't know how great the antibody tests are because of cross-reactivity. So in some ways, a positive PCR test is more convincing than an antibody test since there can be false positives. So advise patients to be cautious in using these tests to make decisions about who they can have sex with and what kind of sex they have. They're not perfect, but again, some data is better than none, and we would just make sure that folks know what they're using rather than having to guess what these tests mean. Next slide, please. So in addition, it's important to sort of work on other areas of sexual health beyond COVID, and we have created some really exciting services during the public health emergency. One is Door to Door, which is an initiative where free safe sex products are available for home delivery. So we have a lot of types of condoms and lubricants, and we are delivering them in multiples of 30 discreetly in packaged envelopes. And you can just go to nyc.gov/condoms, and your patients can order all of the safe sex materials that they need while they're at home. We also believe that HIV testing needs to continue, even though some of the clinical spaces where we do it are closed. So we are still providing this community home test giveaway. Participants receive coupon codes from a partner organization to redeem online for an OraSure OraQuick HIV self-test kit, and it comes straight to their home. So they don't have to go to the pharmacy to pay for it. It comes for free. So they can get a coupon code for testing through a participating community provider by just going to the website below. Next slide, please. Numerous private practices and clinics have now reopened, so sexual health care is starting to resuscitate. Continue to use telemedicine to the extent that's feasible. That does preserve PPE and reduce risk of exposure, and there are and fewer in-person visits enables physical distancing. So if you can manage someone on the phone, try that instead, but if you need to see them, you need to see them. Reassure patients who need STI testing or other in-person services that they can safely get care and should do so, especially if they have been exposed to HIV or need to start pre-exposure prophylaxis. Also, symptomatic STI or exposure to STI should be something that folks seek out care, whether it is via phone or in person. It is also not a bad idea to look at your practice and reach out to patients who are overdue for care or who may be at higher risk of exposure to STIs or COVID-19. Next slide, please. So we still do have sexual care environments that the city is running. There are fewer of them right now. Chelsea and Fort Greene clinics continue to have in-person services, and you can find that online on our website. But additionally, we have telehealth STI services available via the Sexual Health Clinic hotline, and that number is 347-396-7959, and it works from 9 a.m. to 3:30 p.m. Monday through Friday. Additionally, you can go visit our coronavirus site and go to community services to find sexual and reproductive health provider directories by borough. Additionally, the health map, if you go to that, you can find HIV, sexual health, and LGBT health services. And a handy number for all of you to take down during the pandemic or not is our New York City HIV post-exposure hotline. So if someone is exposed to HIV, they do not have to go to the emergency room. They can dial 844-4PEP-NYC, and through telemedicine, they will be prescribed post-exposure prophylaxis after an exposure. Currently, the program is giving out a full 28-day course, so it actually prevents a visit at all. So that will change again when we get back to normal times or more normal times. Next slide. And this is a slide that I won't read because it's an extensive list of our providers and all of the other services that we have, as well as all of our guidance for patients, including safer sex guidance, guidance for people living with HIV, information about COVID testing, as well as citywide sexual and reproductive health provider information. Thank you. Next slide. And I'll give over the mic to Catherine Staten.
Good afternoon. I wish I had a quick-witted way to transition, but I don't, except I'm happy to be with you this afternoon and happy to talk about domestic violence and intimate partner violence identification during the pandemic and beyond. So next slide, please. With you today, I want to build a frame that clarifies and contextualizes domestic violence and intimate partner violence as health concerns. I want to describe the epidemiology of the problem and illuminate how it has manifested during COVID-19 times, guide you providers through identifying domestic violence and intimate partner violence in your patients using the principles of an evidence-based healthcare setting approach called CUES, and to close with some resources for both you and your patients. Next slide, please. So frequently, domestic violence is a term used interchangeably with intimate partner violence. My focus today is largely intimate partner violence, and forgive the occasional use of the acronym IPV. It is a pattern of coercive control used to maintain power, one partner over the other. And it is a dynamic that can occur in current and former relationships and all the shades in between. IPV can occur across gender identity and sexual orientation. Important indeed is the behavior. But to deeply understand the problem and find its remedies, we are wanting to understand that intimate partner violence occurs at the intersection of multiple forms of oppression. And our sustainable remedies come from understanding that. Next slide, please. So the behaviors frequently seen in IPV include verbal forms of abuse, coercive behaviors that involve monitoring and isolating. And then there is the more manifest forms of abuse, the physical abuse that can take the forms of kicking, slapping, shoving, etc., and can frequently generate obvious injury. Sexual coercion is frequently classified therein. Now, during COVID times, there is also very contextualized use of control, including intentional exposure to the virus, perhaps blaming the survivor for contracting the virus, and using the stay-at-home orders in controlling ways, such as in raising the elevation of concern over child custody issues, restricting access to supports, and creating even more fear and risk. Next slide, please. I want to share a bit on the convergence of epidemiologic history of the problem as well as the current pandemic conditions. So the very issues that COVID-19 has brought on, such as grief, economic struggle, food insecurity. These problems are exacerbated for those New Yorkers staying at home who are living with violence, trying to survive violence in the home. And there is the potential that these conditions lay bare violence that wasn't percolating yet, but has started to given these stressful conditions. So the oppression that is underlying the intimate partner violence has also created some of the vulnerabilities to COVID-19. Put those together with the historic epidemiology that shows that intimate partner violence creates disparate and durable impacts on one's health, we have the sad state of a near perfect storm of risk here. Next slide, please. So our local data from our community health survey, a population sample survey, has established the current burden among New Yorkers, with 17% reporting ever in their lifetimes experiencing psychological abuse, and 10% reporting physical abuse. We have seen those prevalence figures be slightly higher among women rather than men, and we see a slightly higher prevalence among Latino women when compared to white women on the indicator of physical violence. Next slide, please. The survey also found, no surprise, that there are higher rates of depression and lower rates of mental health treatment seeking among those exposed to intimate partner violence compared to those not exposed. Again, these are self-reported data. Next slide, please. So given our understanding of IPV as a risk factor, if you will, for health outcomes, while it is also a health issue in and of its own right, we're starting to envision the healthcare setting as a safe space for survivors to go. Therefore, we owe providers supports on understanding it and identifying that. So our goals with you are to increase that understanding of the root causes of the problem, to empower you to identify the violence, and to create an inviting, culturally competent and safe space for patients, and to share very tangibly resources that are available right here, right now, for New Yorkers experiencing this issue. Next slide, please. So the model I want to share with you, the evidence-based healthcare setting model, comes out of an organization called Futures Without Violence. And the name for this model, an acronym that I will use but explain at first blush, is CUES, Confidentiality, Universal Education, Empowerment, and Support. And the confidentiality dimension of this approach, and I do mean approach, it's about building a rapport with patients, starts with an effort to secure a private setting with the patient, see the patient alone for at least part of the visit, and start to discuss relationships at home in the company of the patient alone. Now, there are a couple of regulations in New York State that require a mandatory report out of IPV, and those conditions involve a gun or when burning is a mechanism of injury. Otherwise, what occurs in that conversation can be kept in confidence. The U and the E, next slide please, in the CUES principles, are a reflection of universal education and empowerment. I will get to the empowerment in a moment. The education piece is really a normalizing part of an encounter with every patient that is focused on identifying elements of a healthy relationship and elements of an unhealthy relationship. And some such elements are specified here. These elements are drawn from guidance the health department produced a few years back. But the idea is to give everyone an orientation to when control is in action and when there's freedom in action. Next slide, please. In addition to the education for all, there is empowerment for all, and that empowerment is for both you, the provider, and the patient. The empowerment for the provider, the message for you all is that there is no requirement to fix or cure. The empowerment message for the patient which you can be the conveyor of, the messenger of, is that patients are their own experts about safety, and they have the clearest ideas about how, when to make choices about seeking the safety and resources they need. And it is their time and space and how that happens. Next slide, please. Support is also universally delivered, but it has a slightly different flavor when a patient ends up disclosing that IPV is happening to him or her. And the first version of support is one of validation, acknowledgement that the sharing is profound, sorry this is happening, and that you don't deserve this. Then the second part of the support is the offering of local resources and a support that could extend to being a facilitator of connecting with those resources if so desired. Now, there's also tremendous opportunity to offer support when a patient does not end up sharing this as a part of their lives. There is increasing recommendation to go ahead and say, I know of existing resources on how to stay safe and healthy at home. I'd like to share those with you, and maybe you can share those with others. So next slide, please. The resources I mentioned include the Family Justice Centers in New York City, which in very short order redirected all their service delivery to be remote. Their service delivery right now is still remote, and there is a way to seek that support in each borough. Here are the phone numbers they're in. I want to be real about the volume. It is high, and there's an occasional need to leave a message and get a call back. These exist in a bit of a case management model. There is multi-services available through each center. Case management and identification of priority needs is the beginning of a journey to get additional support. Next slide, please. Should there be a need for support? Not Monday through Fridays, 9 to 5. There is the 24-hour hotline with multiple language supports available. That hotline, not to add to the hotline list, 1-800-621-HOPE is that number. At the very least, that is an easy bit of information to deliver. There's also a website with a very comprehensive list of resources that are searchable by need, by neighborhood, by language, etc., available at the website provided therein. We also have in the city a newly mounted Safe Chat option. Apologies in this slide, that's a hyperlink at Safe Chat. I can provide the web address for that. It's safehorizon.safechat.org. And that's available Monday through Friday, 1 to 6. We also have our NYC Well supports. And in case of emergency, there is always 911. Supreme emergency, I would say. Next slide. The next two slides I will briefly summarize as additional remote service helplines available for our fellow New Yorkers who may have the higher risks that I described at the beginning and may face additional obstacles to seeking support. These are some of them on this slide and the following slide. Next slide, please. Pausing there for a moment and then moving on to the next slide. So by way of near closing, I want to share some overarching tips for this CUES program and some general takeaways to think about. It may be tempting to allow a family member, a friend, a child to stay in the examination room to help with interpretation or translation. We really urge not leaning on that support. It's better not to raise the conversation than to raise it if that's the case, but lean on professional interpreters to use in those situations. Offering the tips about healthy relationships, a reminder that is a service for all patients, not just those who end up disclosing the intimate partner violence. Similar for the service information delivery. And increasingly it has dawned on us that it's important to share the services exist. one can have faith in them, and knowing that may embolden delivery of that information to your patients, because that connection can really be the beginning of a journey of health seeking that will not be swift, but that first step is sometimes the beginning of a whole new, safer life. It is often the case that patients will not reveal that this is an experience they're surviving at home. In due time, they might. Patience and building a rapport is critical in that regard. So to the extent you have multiple opportunities to have this conversation about relationships in the home and with intimate partners, you are increasing the likelihood of sharing this as part of their life story. Next slide, please. For additional resource for you as providers, I want to share that we have some local supports for you from our health department. We have a City Health information on identification of IPV with more detail attached. And I also wanted to share the national resource from which the CUE's work is coming. And next slide, please. To close, I think it's important to understand that we have a problem on our hands that is really rooted in an acquiescence to and an allowance of the ways we treat one another and who has power over another. Those are historically rooted, and unrooting them is going to require quite a movement, and dismantling them the same. And we are envisioning healthcare providers can be an amplifying voice to that and can talk about a nonviolent way of living for everyone. Thank you.
Good afternoon, everyone. I also, like Catherine, don't have a very good transition between her topic and mine. But good afternoon. Thanks to the Provider Communications Branch for giving us the opportunity to share how the city is preparing for heat emergencies and COVID-19 reality. There's been an enormous amount of work here at the Health Department, at New York City Emergency Management, and with other partner agencies focused on the intersection and ultimately the balance of two sets of risks. The first is the risk of transmission of COVID-19 and ultimately severe COVID-19 complications, which we are mitigating by advising New Yorkers to stay home, particularly those at greatest risk. The second risk is an impending heat wave, which poses significant risk primarily for those staying in homes without air conditioning, which are too hot. Next slide, please. Heat planning is led by New York City Emergency Management, with multiple city agencies and the mayor's office partners, including us here at Health. The work over the past several months has been focused in three main areas. First, we're working to expand prevention efforts to keep more people who are vulnerable to the heat safe in their homes. Second, traditional strategies are being expanded and adapted to provide relief from the heat outside of homes. These are cooling centers and outdoor cooling, which involve water strategies. And third, how do we message these new, different, and expanded strategies based on both the current reality when the heat strikes and help New Yorkers to effectively balance these risks? New York City has been working in partnership with the National Weather Service and Emergency Management to set heat advisory thresholds for New York City. Research conducted by DOH shows thresholds at which we saw significant increases in heat-related morbidity and mortality. The National Weather Service has incorporated these thresholds into their heat products, and the heat plan activation automatically tied to the weather forecast. So as seen above, we see a heat activation as well as excessive heat actions if the predicted forecast goes to the last two bullets. Next slide, please. So before I dive into what we're doing, a quick reminder about why we care about this. Heat is not just uncomfortable, but has very real health impacts. When we look at morbidity and mortality without a pandemic, we see significant morbidity and mortality both directly due to heat and from the exacerbation of chronic conditions. there's documented increased risk of death both during and immediately after heat events among non-Latinx Black New Yorkers. Our research on heat impacts among New Yorkers have led us to pushing this message for years. Air conditioning saves lives. We know that most heat stroke deaths happen to people who are exposed in hot apartments without working air conditioning. People are literally cooking to death in their homes, in these homes that can be significantly hotter than outside, and they stay hotter for days after the heat event has ended. Further challenging our planning is the intersection of the COVID-19 complications and risk with these heat risks and mirroring and possible exacerbation of the inequitable impact on our Black and Brown communities. Finally, even having an air conditioning does not necessarily mean that people are protected, because the cost can be a significant deterrent. So what can you do as providers? Well, remind patients of the danger of the heat. Advise them to listen to trusted news outlets, city messaging, and to use their air conditioning, setting remain hydrated. Their air conditioning systems and considering advising them to safely reach out to family, friends, and neighbors who can offer brief respite even in this age of COVID-19. Next slide, please. As with all other messaging challenges during this pandemic, heat promises to be similarly hard. Messaging right now is focused on prevention first. We released the annual HAN, the Health Alert Network message, on heat preparedness about 10 days ago, and both our colleagues here at DOH and at Emergency Management have been spreading the word on getting ready for the heat. In addition, we are working on messaging for those with and those without air conditioning, outreach to those who will get a utility discount so they realize they can use their air conditioning without cost concerns, and reminding people of the dangers of heat, and above all else, encouraging New Yorkers to do what we do best, looking out for one another. During COVID-19, we are also encouraging people to consider offering their own cool home to someone who may need a place to cool off, and to those without air conditioning to think about whether there are family or friends they could visit for even just a couple of hours to cool off, as mentioned just a moment ago. Our Be a Buddy program partners in the Hunts Point, Brownsville, and East Harlem neighborhoods are already activating their networks to help communities shore up social networks and support those in need. Next slide, please. Which leads me to the unprecedented step the city has taken to address the need for in-home cooling, a need always present, but even more important this year. The city is currently running Get Cool NYC, a new $55 million program that is purchasing and installing 74,000 air conditioners in the homes of low-income, heat-vulnerable New Yorkers. 22,000 of these air conditioners are going into NYCHA housing, and overall the eligibility for the program is age 60 or older with an income of less than 60% of the state median income, which is confirmed against the state of existing benefits and not having a working air conditioning at home. Get Cool is designed as an outreach program. The city has pre-identified more than 500,000 New Yorkers, older adults who are currently income eligible clients of either DIFTA, the Department for the Aging, HRA, the Health Resources Administration, or Department of Social Services, and Housing Preservation and Development. And more than 1,000 city workers right now and partners are literally making calls every day to find eligible New Yorkers and getting them into the program. As of last night, we had roughly 35,000 clients opted into the program and almost 22,000 air conditioners installed. Next slide, please. The city had another huge success 2 weeks ago when the Public Service Commission, the state regulatory agency for the utilities, granted New York City petition for increased summer utility relief for low-income New Yorkers. This program will distribute about $35 a month for the months of June, July, August, and September through automatic bill discounts to help people run their air conditioners without worrying about the cost. Recipients will be current clients of Con Edison's low-income bill assistance program, which has about 440,000 New Yorkers. In addition, we are continuing to pressure the state to modify the home energy assistance program's cooling assistance, although, to be fair, have seen little progress in this. The city submitted a waiver request to modify the program, supplement it with the COVID CARE Act dollars, specifically earmarked for heat, that adds utility assistance as a benefit and relaxes the benefit requirements and eligibility. We're still taking on this site, and we'll carry this over into the future. Next slide, please. Although these prevention efforts are amazing, we know there will still be those without air conditioning at home who will need an option to get cool this summer during a heat event. In addition, with many businesses and other cool spaces still closed, there will be even fewer options for people. As a result, emergency management is evaluating traditional cooling centers, which are managed by partners, for viability in our COVID-19 reality. They're focusing efforts on identifying centers and communities with high heat vulnerability based on our own heat vulnerability index that we've conducted at the health department, looking for places that can open quickly and maintain necessary social distancing and other COVID-19 transmission mitigation practices. The health department developed heat health recommendations early in May, in which we recommended that non-congregate options be developed for New York with highest COVID-19 complication risk. But without decreasing transmission rates, making heat risk paramount in a heat wave, we have modified these original recommendations. Cooling centers will now be open to all who are not sick or in isolation or quarantine, but with strict adherence to mitigation measures. Planning is still evolving for the last risk positive or those in isolation or quarantine, but will likely lean on operations designed for those who do not have safe places to isolate, regardless of the weather. There are additional outdoor strategies. I'll hold off on talking about those, mostly in parks and water and access to the spray cap programs. They'll know that there'll also be water bottle campaigns to encourage hydration, and open streets may offer opportunities for additional outcooling opportunities and efforts. So just in closing, heat, just as a reminder, it's not just uncomfortable, it has very, very real health impacts for some of our most vulnerable New Yorkers. And thank you very much. I think we'll go back to the moderators for some questions.
All right, thank you so much, Seth. And then Allison, can you start up the poll? There we go. So, all right, I'd like to alert everyone to the poll here, which you can fill out while we do questions. Again, this will really help us get you the content that you need in the future. I also want to remind everyone that on our provider webpage, which we've put in the Q&A a couple times, we can also throw it in the chat, but the recording of this talk and the slides will be available on that webinar, on that webpage under the webinar tab by Monday, probably tomorrow. And so we have a couple of questions here. So the first question is for Dr. Gaslowskis. So can you talk a little bit about the interaction between healthcare providers and contact tracing? You know, some providers have said in the questions that they want to do their own contact tracing.
So the question is about doing contact tracing by yourself.
By yourself, and then just about how how Trace is going to interact with providers.
Got it. So, so a couple of things. So speaking for Trace, which is, again, a program that we work very closely with through the Health and Hospitals Corporation, or sorry, Health and Hospitals, I forgot. I'm so old, I keep calling it HHC, Health and Hospitals. Trace is really focused on reaching out directly to someone who's diagnosed with COVID or with their contacts. So they're using a very sophisticated system that we have at Department of Health We're sharing data with them to be able to see through lab reporting when there's a new case of COVID identified. So there's no need for a provider to call in to report a case of COVID. So we are hearing about them through lab reports. There is a possibility that folks from Trace may reach out to providers if they're having a problem finding the patient. Very similar to what we would do during other case investigations. If we need to find someone, the provider tends to be a really good source. So it would not be odd for you all to expect a phone call from Trace to say, hey, do you have Dimitri's phone number? Or, and so they will identify themselves as part of this program, and you should feel free to share data with them because it is a public health response. Secondly, about doing your own contact tracing. Well, technically, we're all supposed to. So if you identify a case of a communicable disease, it's always good to talk to your patient and identify who their contacts are and work with them to notify. It is also good to tell your patients that Trace is going to be calling them because they will also be doing this in tandem. But there is nothing wrong with people who are contacts hearing it both from the case's provider, or potentially from Trace as well. So the more we reinforce quarantine and the more we reinforce isolation, the better it is.
All right, thank you, Dr. Daskalakis. And then we have a question for Dr. Staton. And this is, if you identify someone who is suffering from domestic abuse, or that you suspect is suffering from domestic abuse, we had a specific question about housing for them, but can you speak a little bit to the resources that you can connect those persons to as a provider?
Well, there begins the conversation about choice. Every resource listed will have the capacity to identify safe shelter. And there are safe shelter spaces available now, and there are some creative ways to get to safe spaces. But the direct pathway from the healthcare setting to safe shelter is best navigated with some of the services named in between. And the Family Justice Center is often a very central place to start to help identify what the next best step would be. So depending on what borough the provider and patient are in, I would recommend starting with the Family Justice Center. Was there a second question there?
Oh no, I think you answered that. I think that's really what the question was looking at. I think they were specifically asking about housing, but I think you gave the most complete answer. And then we're going to do, in our very last minute, let's ask Dr. Foote if she can tell us a little bit about eye protection and COVID and the risk of transmission.
Hi, sure. So really there's very little data available that looks at transmission risk when it's just eyes uncovered. Generally, the data that we have from previous, like MERS and SARS, and so far with SARS-CoV-2, it's looking at with or without mask, but doesn't usually report on eye protection. So where this recommendation really came from, so with droplet precautions, you do want to protect both your kind of main portal of entry for droplets, which would be both your eyes and your mouth. So that's why that's part of the recommendations for COVID care. But where this recommendation came from for eye protection for all clinical encounters is just we now have a much better understanding of the risk that people can be carriers or have detectable virus even without symptoms, and they can also be potentially quite infectious days before they develop symptoms. So this is really a way to protect healthcare workers from inadvertent exposures to asymptomatic or pre-symptomatic patients. And we are certainly expecting, we are hoping that healthcare providers can get into this habit of wearing eye protection with masks, and that will provide much better protection for the workforce during, especially looking towards flu season and upper respiratory viral season. And that's all.
Thank you. Thank you, Dr. Foote. I think we are at 3:01, so I think it's time to close the webinar. I'm just going to say happy birthday to my mother again in the last minute of this, and thank you all for joining us. Reminder also, the webinar will be bi-weekly during the summer, and so we will not have a provider webinar next Friday, but we will return the Friday after that. Okay, thanks everyone.